My name is Joshua Jones. I'm the founder of Compass Rose Healthcare Training, and today we're going to go over a central line placement. So, my approach, a little bit different than the traditional approach. I think the steps that I show you today are going to make it a lot easier and also make it a whole lot safer. So, when we talk about central line placement, we have to talk about the different complications that can happen when you're placing a central line. You have arterial stick, you have hematoma, you have pneumothorax, you have air embolism. All concerning things, but if you follow these steps, it'll be pretty hard to cause those complications. So, once you get to the room, go ahead and assess the situation. Figure out if it's emergent or non-emergent. If it's not emergent, take your time, breathe, check on your nurse, check on your patient, and get ready to get to work. So, next step is ultrasound. If you have one available, use it. It helps to visualize the vessels and it makes things easier. So, remember, north, south, east, west. You want to make sure, put your gel on. Right is right, left is left, center is center. Then next, what I do is X marks the spot. Pick your spot and then chlor prep all around the surrounding area. So, you let the chlor prep dry and then you go get your equipment. Before we leave the room, pay attention to the patient's temperament. Were they nervous, anxious? This is a good time if you need to use some anxiolytics or analgesics. Now's a good time to do that. So, you walk over to the supply closet and you're going to need only 3 things from the supply closet. First thing, in my opinion, most important, is the micro introducer. Essentially what this is, it's a 22 gauge echogenic needle, much smaller than the 18. Comes with a floppy wire, much gentler than traditional wire. And you get a 5 French catheter and it has an inner sheath and it's tapered. So you don't need to make any cuts or incisions. So that's the micro introducer. We'll talk more about that later. The other thing is 2 gloves. Probably only need 1, but it's nice to have 2 in case there's any tears, or if you have trouble with dexterity and you would like some help from your nurse. When it comes to central line kits, typically you have 2 options. You can get a 16 or 20, could get 23 if you need it. Typically, though, those are not in stock, and you can get away with a 16 or 20. So if your X is right here at the clavicle, you're probably going to want a 16. If it's a little bit up, you're probably going to want a 20. I usually err on the side of caution. I just get a 20 because it fits for most patients. So that's all you need, and then you can go back to the room. So, little side story. You walk in the room, and patient's blood pressure is crashing. 60/40, nurse is asking you, what do you do? Thankfully, you've already mapped, chlor prepped, X marks the spot, and now you've got a central line. 5 French catheter. Quickly stick, insert the catheter, and you bought yourself time. So today we'll go just for a typical right routine IJ. The first thing I do when I enter the room is I go ahead and get set up. I like getting a table. I wipe the table off. I have it on if I'm doing a right IJ, on my left hand. And this right here is my working area. Everything kind of chest level. Patient's head right there, and the bed. Make sure the bed's where you need it. your back will thank you. Also, if you want to tilt the bed Trendelenburg, that'll give about 250 cc's or 500, depending on the patient. And that will make your IJ very big, and you'll be able to access it a little bit easier. So, before we get into my approach, I want to talk about traditional approach and why it is not ideal in most circumstances. So, trajectory of the needle in traditional approach is going to be just about right here. Ultrasound is going to look on the screen. The needle will look the same here, and it'll look the same here at the tip. So you have to be pretty precise. This approach with novice proceduralist can sometimes lead to trouble. So how does it lead to trouble? This is your vein and this is your artery. You can imagine if we're going down this way, you could hit the artery. Also, down there right at the clavicle, especially if your X is right here at the clavicle, you got your lung very, very, very close by. Also kind of in the line of fire. So the way I describe the traditional approach is more so like pool. If you're good at pool, you're good. You can keep playing pool. But what if you could play darts? Darts are more accurate, darts are more precise. So, how do you play darts? First, you want to talk about the positioning. This right here, stacked. Stacked is good. How do you get them stacked? A couple things. So, artery, vein, turn your head left, it's going to drag over. If you go up, also going to drag over. Stacked, stacked is good. So now we're stacked. You got the vessels aligned just how you need it. We want to talk about ultrasound. So earlier, when you're going this direction, you can't really see the needle very well. Imagine if you could see your whole entire needle, the whole entire way. So now, you watch your needle go all the way, sinking to, not an artery, but a vein, to the center of the vein. So we talked about a horizontal needle. When you're playing darts, you actually don't need a syringe. A little bit harder to control. So now, you just use this. And as I showed you earlier, we're doing a horizontal approach. So that's going to be a benefit for quite a few reasons, but one of them is you get to see your needle all the way through. Also, this is stacked right here. Imagine this is the vein. If you need to, you can go through and through. No detriment to the artery down below. Also, if you're going parallel to the lung, you're not going to hit the lung. So those three main complications, not a problem anymore. Also, you get a benefit from gravity. So we're going horizontal. Blood flow is going to be a little bit better horizontal than it is vertical. So as soon as you stick it in, you visualize it the whole entire way in the center of the vessel, and then you watch. Drip, drip, drip. If it's pulse, 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 then you might have a little bit of concern. But keep in mind, color and flow is not always the most accurate. Sometimes with hyperoxygenated patient on vents, it could be very, very red, and sometimes when they're on pressers, it can also have a pulsatile-like movement to it. So trust your ultrasound, get really good at this, and visualize it right there in the dead center. So your needle's in the center. Next step, you gotta change your angle. So you go about 2 centimeters in, change your angle. This is a very slight movement, and then you wanna lock that needle in place. And I want you to remember what that IJ looks like. Very durable. So you get in the center, you go about 2 centimeters in, and then you change your angle. At this point, you're ready for your floppy wire. The chamber of the 22 gauge is filled with blood. The floppy wire goes right in, and then you're going to wire out your needle. And then you grab our friend, the micro-introducer. Micro-introducer, tapered end, but it is pretty tricky to get on. So you're gonna have to most likely take your hand away from the wire. It's not gonna suck in the patient, and then thread it in. As soon as you have the end right here, secure it tight, and this is like a mini railroad, and then you railroad it in. Overhand grip, and I'll explain micro skills later on TikTok. So your catheter's in. Now you got to get your floppy wire out and your inner dilator. That's the blue part. So they come out at the same time, and this is your second check for an arterial hit. You're very confident you didn't hit the artery because you watched it and you saw your horizontal blood flow, drip, 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 but now you get a check again. So blood's gonna fill the chamber, it's gonna drip, drip, drip. You watch the color as well, and then you cap. Once you cap, you go find your big boy wire. So, use the cheater, try to get it in there. Sometimes the cheater falls off, and you're left with a J-tip. Then you gotta figure out how to get that J-tip in there. What you can do, grip it, straighten it, but I just kinked my wire, and we don't put kinked wires in the patient. So all that fails and the cheater doesn't work, you can use the back end. But for all intents and purposes and teaching purposes, we'll pretend the J-tip worked, you got it in, and you go to your third check. Very important, third check. Secure that tightly at the skin. Next step, you gotta get your dilator on, but your dilator needs some help. It's very strong. It's the cause of most of the bad complications. It'll kink your wire, perforate vessels, perforate veins, perforate arteries. It can wreak havoc. The weakest part of this thing is the very, very tip of it. If you give it any chance, it will fray. Fray dilator just means trouble. So the dilator's biggest enemy is your skin. You have to get rid of the skin. If you have a young patient, they're gonna have tougher skin. Keep that in mind. Older patient, maybe not as tough. So how do you get rid of the skin? Scalpel, hemostat. Scalpel in, parallel, blade up, make your incision. Remember earlier, you already know your depth from the ultrasound. You know exactly how far you can go. Typical good length, as I'll have on Instagram photos, a little bit above the blue. Sink it, make room for your dilator. He needs you. He will not make it in without you. So, track looks good. You're able to move your wire freely. You have 4x4s close by if you are not sure and can't see because a little bit of blood. Give it a little dab. Then load your dilator, secure it right there in the skin, a little bit of firm pressure, and this is going to be our dilator. Remember, we don't have to go all the way in the vessel. We just go right there to the edge because remember what that vessel looks like. Only have to cannulate the outside. So this is your wire. Wire's in. If it can move freely, you can advance. Always advance a little bit more. Maybe you're out right about there. Move your wire, you're good. Now, you need to remove your dilator. So when you remove your dilator, I want you to remember this hand. 2 fingers, hold, pull your dilator out, and save it for later. So, 2 fingers, very important. You look like a pro because at this point it's going to want to bleed a little bit. Again, you have more 4x4s in there you can use if you need to. Clean things up before you put the central line on. Secure wire, and now you want to grab your central line. If you need to have your nurse or somebody help you with the dexterity part of it, now would be the time to grab that second pair of gloves that we had earlier. Keeping sterile. Secure your wire. You can loop it so you can keep holding your wire. Feed it through. And then if you put it to the 3rd check, you're only going to have to go about this much, about 2 centimeters. So, feed it 2 centimeters, and the second it comes out, it'll come out this brown port, most distal port, 16 gauge port, and the other 2 should already be capped. So it comes out, second comes out, secure it. 2 fingers, anchor. This arm does not move. You just set your railroad. And the railroad tracks do not move unless you tell them to. So now you have enough in the patient to guide your central line. You have enough out that you can feed it. And then you send it through. At this point, you want to check your work. So go ahead and aspirate, flush all 3 ports. They look good. Then you can go ahead and secure it. And remember, when you're placing the central line, you can always go deeper, but you can't go too short because then you might have to redo it. So if you get the x-ray later and it comes back and it's too deep, then you can pull back. But if it's too shallow, you can't go forward. So err on the side of going too deep. That's why typically a 20 is going to be a little bit more beneficial. So now you just got to dress it up. You're almost done. You get your hemostat, put that on. You got 2 anchors. White goes on first, blue goes on after. Grab your suture. And now we talked about using our friend again. So if you want to look like a pro and be very, very thoughtful to the patient, you can use this. So imagine you are tying your knot and there's a circle. Before you cinch, you have this in the middle, and then you cinch. So now there's a little tiny circle on each clip of that anchor. Supposedly it's a whole lot comfortable for the patient. Do anything you can to help out the patient. They're getting a central line, so their day really hasn't been too great, and you can make it better. So that is about it. I think at this point, clean up your sharps, take the dressing off, call x-ray, because you just placed the perfect central line. All right. So thank you guys for hanging in there with me today. If you guys have any questions, please follow us on our links. I'll have them listed below. And we'll see y'all next time. All right, stay ready.